This
see,
conference will now be recorded.
Henri and Vic. And so we'll try and get through Henri and Vic, and then Jim S. And the other two gents, John and Ed, would please come back next week. As you can see, we have a lot of people, and we have guys who are regulars, and we don't want to miss them out. So here's what we're going to do, and we'll probably whistle through this a little quicker. We're going to ask you a bunch of questions. I'm going to start off with Henri. Are you with us, Henri?
Yes, sir.
And should I be saying Henri or should I be saying Henry?
You can call me anything you want, but I go by Henry, but you can call me whatever you want.
Henry. Sorry.
That's all right.
You must be from Louisiana with a spelling like that.
No, it's Alabama. Roll Tide, everybody. I know everyone loves Alabama, the football team. We can go ahead and get that out of the way.
Okay, thank you. What's your name? Henri, what's your last name?
Cornelius, Cornelius.
Excellent. And how old are you?
54.
54. Okay. So you should know, by the way, we also have an under 60 group for men with stage 3 and stage 4 that Ken Anderson leads. And we'll tell you about that before we leave. One last thing to tell you. For those of you who are new, there's a chat window in the top. If you're on a PC, it's in the top right-hand corner with a question mark bubble. And if you click on that, you'll see a whole bunch of stuff that's already in there. So you live in Alabama, whereabouts?
Birmingham.
Okay. And when were you first diagnosed, Henry?
Friday the 13th, August 13th.
Oh, man. Okay. Of this year?
Yes, sir.
Okay. What was your Gleason score and your PSA level at diagnosis?
PSA was 45, Gleason 9, 4 plus 5, I guess, and I've heard grade group 5.
Right, got it. And who diagnosed you? Was it at the University of Alabama, Birmingham, or was it a urologist, or who was it?
UAB.
Sorry, what was the name?
UAB, University of Alabama.
UAB, it was UAB. Okay. And before you began any sort of treatment, did they do any scans?
Yes, sir. Negative on all the conventional imaging, CT, pelvis, abdomen, chest, bone scan, MRI. Had a fluciclovine PET that revealed 2 likely lymph nodes. And skipping ahead, we found 8 at surgery. 8 of 27 were taken. I'm sorry, 27 submitted to pathology and ended up finding 8 that are metastatic, 8 lymph nodes.
Got it. So, so your initial treatment then was a robotic radical prostatectomy?
Yes, sir, at MD Anderson.
Oh, okay. And who is your quarterback doctor at this point in time?
Brian Chapin or Chapin, Chapin at MD Anderson is the surgeon. We're going to Dana-Farber this Thursday to meet with Anthony D'Amico and Mark Pomerantz. And so I don't know who will end up being the quarterback. That's part of what I hope to hear from all of y'all privately.
Yeah, we'll talk about that.
Sir?
We'll talk about that. I mean, okay. You know, I can see why you would want to see D'Amico right now, but you've got some really good choices at MD Anderson. And I think if it were me personally, I probably would start there. Although you're going to need a medical oncologist on your team, a Genito urinary medical oncologist. I don't know Pomerantz. Is he a medical oncologist?
He is. He came to Dana-Farber from Sloan Kettering.
Yeah.
But let me back up. Our follow-up appointment with MD Anderson is this Wednesday. That's a virtual to go over the pathology report, which is very challenging. So the post-surgical visit with MD Anderson is this Wednesday, and then Dana-Farber's Thursday.
Okay. See, I don't know Pomerantz, but I know a bunch of great GU medoncs at Dana-Farber that we could recommend in a heartbeat, and also at MD Anderson, and also at Houston Methodist. So, but Pomerantz is not a name that I'm familiar with. So let me just make a note here. So you said you had, was it 8 lymph nodes that they found metastatic?
Yes, sir. 8 of the 20, 8 of 27, and then positive surgical margins, both seminal vesicles, extra prostatic extension.
Right.
Go big or go home, baby.
Yeah, you ain't kidding, boy. Where right now, are you on any? What was the date of your RP, by the way?
It's 21 September.
Okay, so it was late September, and are you on any type of treatment yet or not?
Red wine. No, sir.
This guy's gonna be a regular with us, Jimmy. You got competition.
Hey.
You got competition, Jimmy.
I'm ready.
Don't talk with your mouth full, Jimmy.
I forgot to mention that my first PSA, unfortunately, post-op is 4.08.
Thanks. Okay. No, I should have asked you and I didn't. And what kind
of moderator are you? I mean,
that's right.
Heard all these great things about you. It's a kindergarten class so far.
Now, tell me something. Was your post-op pathology, did it confirm 4+5?
Yes, sir.
Okay. All right, look, let's dive right into this. We all know you got to have to. Oh, have you had any genetic testing done of any sort?
No, sir, not yet.
Okay, so we'll touch on that. Let's just dive right in here in terms of our philosophy at AnCan is that in a situation like yours, the most important person is going to be your GU medical oncologist, and not the radiation oncologist. We know from experience a bunch of these guys around the country. I am super impressed that you've gotten yourself to the right institutions, and you probably figured that one out. If it were me, I would probably stop at the GU Medonc before I went to see D'Amico. And we're happy to give you names. I'm looking here. Yeah, we've got people on the call who are seeing docs at MD Anderson. Do we have anybody right now seeing anyone at Dana-Farber? I don't think so, but we can give you some great names at Dana-Farber. And one of them would not be the guy. Who did you say the guy was that you're seeing with D'Amico?
Rick, I just looked up Pomerantz very carefully.
Pomerantz.
And I don't think I'd be afraid of him.
I'm sure he's great. And the only thing I would say is the names we're going to give you are people that we know work really, really well with patients. In other words, we know they have a great patient manner. And I've never known anybody see Pomerantz, so I don't know. So I'm sure he's good. But for starters, we'd recommend Alicia Morgan's, who you might have seen on a bunch of videos. Morgans. We'd recommend Sweeney in a heartbeat, Chris Sweeney. These are all at Dana-Farber. We'd recommend Ellie Van Allen if you can get to see him, because he doesn't have a large clinical load. He's got more of a research load at Dana-Farber. I'm trying to think. Oh, yeah, there's a guy with an Indian name who I really like, who who looked after Professor Bill. Hold on a minute, and I'll give you his name. It starts with an A.
Hey, Rick, I definitely want to hear this, but we're not ditching MD Anderson yet. I mean, we're just gonna.
Okay.
That's part of what I want to get from this group.
Get out. Okay, so I'll put that in for you later. I'll put the other guy in for you later. At MD Anderson, so probably top pick would be Paul Korn, who Ken sees. CORN, and I'll let Ken tell you about Paul momentarily. Anna Aparicio is good. And then somebody we like a whole heck of a lot. She was 14 years at Anderson until October the 1st, and she just moved over to Houston Methodist. And I like her particularly for younger men, is Eleni Efstathiou. Eleni Efstathiou is Efstathiou. And she is on our advisory board. That's how much we think of her. She's great. I mean, these are people that have, all these people have just a great patient manner. They really care about their patients. I mean, Korn blew me away the first time I ever had a meeting with him, because I was with a guy who had spindle cell disease, which is really serious. And we navigated him to Korn, and the first thing he said when I was on the call is, "How are you feeling?" No, I mean, how are you feeling? And that was his first question. And he really cared. So, Ken, why don't you say a few words about Paul?
Okay. I must admit, I had a rather long conversation with Staci, Henry's wife, this morning.
Oh,
okay.
So we talked about MD Anderson, and I also pointed him to Logo, but maybe our experience, or AnCan's experience with some of the guys with Christopher Logotheus hasn't been good, or I don't know. So I don't know if the Logo's taken any patients. He used to be the chair there. But I'd definitely ask for him if you can get an appointment with him. But I love Paul Korn. The very first thing is, he'll give you his direct email. He doesn't have staff people reply to his email. I mean, if it's a serious question, he'll get back immediately. If it's just kind of an open question that doesn't really need a reply, he may take a couple days. And you'll find, his plate's pretty full, but if you have a real important question and you send him the question, he'll reply pronto. So I like him a lot. I don't know what else I can tell you.
Here's what I would say about Logothetis. He's old school, and sometimes some of the old school docs can be difficult, as you will hear from others in this group, and they've had to change. And if it was me, I wouldn't go to Logothetis right now. He wouldn't be on my list, given some of the other doctors who are who are available at MD Anderson and at Houston Methodist.
Gotcha.
So my second choice there would probably be Aparicio. There's someone I'm not thinking of right now. I just can't remember their name. But I would also give very, very careful consideration to Dr. E. Because she's not a, I mean, she's a PhD, she has a PhD as well. She's really smart, but she's also she's a character who will appreciate your sense of humor, Henry. So I mean, I could just tell from the way you're talking, you'll connect with her right off the bat. And I would definitely want to give her a whirl. I would not be concerned about the fact that she's moved from MD Anderson to Houston Methodist. She's done that because she wants to take Houston Methodist to a whole nother level. And I would, all these docs you can see in videos. So it's worth Googling them to get a sense of them and how they come across, and if you like the way they come across.
Okay. Thanks.
Henry, what's your current PSA?
4.08.
I got a quick question, guys. I don't mean to sidetrack us, but what? Oh, I might be losing us. Oh, lost our signal.
Yeah, we can hear you, Dr. John.
Oh, you can. Why are we talking about Dana-Farber for a guy that lives down south?
Well, you have to ask him why he decided that he wanted to bring them into the reckoning.
Okay.
I watched D'Amico's and Pomerantz's, my wife and I did, I'm reminded, watched a video presentation that they gave their 21st annual symposium, and were impressed, and I emailed D'Amico on a Sunday and said I had sent him my path report from MD Anderson and said, I'd like to come see you. And he emailed me back in 10 minutes on a Sunday and said, absolutely, come on up.
So you were filled with confidence, I see, despite the
Well,
distance.
and hope.
Yeah.
And I've loved the experience at MD Anderson. I just want to get another opinion, and heck, I mean, I might go to Sloan Kettering next, or Hutchinson in the grasping at straws department.
If I may
Yeah,
just
okay, very good.
add, he is a little bit in despair, at least certainly very, very sad, and thinks this is the end. And I keep telling him we have a lot more to do. And we didn't have a fantastic post-op experience with the surgeon at MD Anderson. He's been very unresponsive, no personal contact whatsoever, really didn't give us a great idea of what to expect post-op, sent us home with both a catheter and an abdominal wound bag, which we were ill prepared to handle. The wound bag remained in place for 4 weeks. And so it was just a lot with no response. So it kind of turned us off to MD Anderson.
Yeah.
Can I say something here, Rick?
Yes.
Which is, you do not want to give up hope. You know, we're a bunch of guys diagnosed with Gleason grade 5 cancers. And, you know, when I was diagnosed, the first thought I had was I'm a goner. And then my GO oncologist said, look, our goal is to make this a chronic condition. And that's what you need a doctor to do for you. And it can be with appropriate treatment and, you know, maybe a little bit of luck, that can happen. So Celeste, I think you want to, and Henry, you don't want to jump all over the world, because there are relatively straightforward protocols for this. But you do not take the attitude that this is the end immediately.
Thank you.
You know, there's something that's going through my mind, Henry, that might be a really good trial for you. It's just been opened. It's a castrate-sensitive Lu177 trial for men who are largely hormone therapy naive. And I think you would fit that real well. And it's something that I really think that you should be looking at, both with whichever doctor you select, and with I'm trying to think, and with the radiation oncologist. Hold on, just give me one quick second, and I just want to pull it up. So I know that it's being offered in. It's only being offered in 2 places, and I can only remember one of them. One place is in Omaha, Nebraska, with Luke Nordquist, who's a good doc, and the other is, bear with me, and I'll find it. Len, you remember we talked about this during the week, right? Hold on a minute, and I bookmarked it so I can get to it very quickly. And this is a trial really for certain people, and you might really fall in well to this one. It's called
is he hormone naive, Rick?
Yes.
Oh yeah, there was a trial, a lutetium trial for hormone naive.
Yes, and it's okay. I'm gonna put the trial. I'm gonna put the link in the chat window right now. There's the link. It's called the PSMA addition trial, and it's being offered in at Nebraska and Jacksonville. There you go. There you go, man. That's Cancer Specialists of North Florida in Jacksonville. I don't know that center. I don't know the PI is somebody called Miten Patel, but I would be, and it's recruiting right now. I know it's open because Novartis advanced accelerator applications told me about it this past week. That's how I found out about it. That is, you could really slip into that, and that is a really, really exciting opportunity for a man like you.
Thank you.
That is huge. And you know what? The sort of doc that you want locally to go with it, and again, I don't mean to sound biased, but there's reasons why I'm saying this, is Dr. E. If you go see Dr. E, you go make an appointment with her and say, Dr. E, what do you think about this? Can I work with you and work with that? She's going to do that. And you may get more pushback at Dana-Farber or MD Anderson. So think about that. We got to move on. I'm sorry, I could talk to you for another half an hour.
You can call me tomorrow, baby. I'll talk to you all day long, listening to your accent.
Okay. So, Henri, do we have your email address? Does Ken have it?
I'm going to put it in the chat room.
Okay, stick it in the chat window. We'll get you signed up, and then Ken's told you that he's got his under 60 group, right?
Yes, sir.
Okay.
Thanks,
so,
everybody.
Yeah, and keep talking to us. And I really want to encourage you to look at that trial and select somebody quickly.
Thank you.
I want to get you into that trial. And if there's any issues with the trial, we have really good relationships with AAA. AAA is the Novartis company that is that makes the drug that they're testing.
And 4, thank you.
Okay. Next up, you sort of heard the way we're going. Look. Who? Let's see. It was Vic. Vic, you're lucky number 2 today. Hello,
Okay,
Vic.
thank you, Rick, and thanks to all you regs
Vic,
who,
what's your last name?
P as in Paul, AGLISOTTI.
Oh, you got a countryman, Sierra.
I do. Who is this?
Aliasotti. He's one of your boys.
Benvenuto.
Ciao.
Vic, how old are you?
68,
And where do you live, sir?
St. Louis, Missouri.
Okay. St. Louis, Mo. And when were you first diagnosed?
Early May of this year.
Okay. And what was your Gleason score at time of diagnosis?
10, perfect 10.
Ooh, a 5+5. And your PSA?
It was 9.6.
Yeah. And what type of doctor were you seeing and where when you got diagnosed?
That was a urologist at Urology of St. Louis did the diagnosis.
Okay. And tell us what they found in that, other than 5+5, how many cores and any information you have like that?
They took 12 samples out of the biopsy. I don't remember the exact number of cores that, how they, it was all 4s and 5s, 4s plus 5s, 5s plus 5s.
Were they all positive?
Yeah, all 12 were positive.
Okay,
all 12 samples.
12. Did you have seminal vesicle invasion?
They didn't mention that.
They didn't mention that. That's good. It's good that they didn't. A lot of times when you see 12 or 12, it often comes with seminal vesicle invasion. It's kind of common. Was there any extra prostatic extension?
Not that I'm aware of.
Okay, that's kind of good too, and unusual for that much cancer.
Yeah, they said it was low to have that low of a PSA score too. My skeleton was lit up like a Christmas tree.
Yeah.
On the CT scan.
So I'll come to that, but what I want to say to you is it's not unusual. And
Okay.
It bugs me when the docs say that to you, because a lot of times we see, when you said 5+5, I thought you were going to say to me your PSA was 5 or 6 or 4.
Oh.
And the reason is because a lot of times when we see 5+5, it's quite common that you don't see cancer that makes a lot of PSA. Because it's already changing and morphing into something else. And so, urologist who tells you that says to me he's not that experienced. That's what it would say to me if that's what the urologist said to you.
Well, what they said was it's not common.
Not.
Yeah.
No. 5+5 is not. It's not that common, but it's unusual. It's not that unusual. So tell me what the CT scan showed. You lit up like a Christmas tree?
Yes, the skeleton and skull all lit up like a Christmas tree, lesions everywhere. Diffuse is the way they said it. Widespread diffuse.
What treatment? Well, next question, I guess, is who are you seeing now? Who's your quarterback?
Right now I'm with a medical oncologist. His name is Paul Tracy Meehan. and he's at Missouri Baptist Cancer Center in St. Louis.
Do you know if he's a general medical oncologist?
Yes, he's a medical oncologist. Yeah, he's
And
the
is
head
he
of the
general?
I don't know if he's I don't know what the difference between general is and you know.
Can you spell his last name?
Meehan, Mehan. Paul Tracy.
So it's really important that you be seeing a specialized prostate cancer medical oncologist, what we call a Genito urinary medical oncologist.
Okay.
Or GU Med. You'll hear us say GU Med Onc, which stands for Genito Urinary Medical Oncologist.
Okay.
And it's really important. Now, I'm pretty sure there's a guy, I can't remember his name, at WashU.
Yeah. Siteman is the big cancer center here in St. Louis, associated with WashU.
Right.
Bullock is kind of one of the head hitters there, I believe.
Hold on a minute. Let me just look at one thing. That there is a guy at Sideman, but I can't remember his name. But you have to get your ass over to somebody who has a lot of experience. What treatment has Meehan recommended?
He's basically got me on the Peace 1 study protocol right now. If you're familiar with that, that's the ADT plus prednisone plus early chemo plus abiraterone.
Abiraterone, yeah.
Yeah. So that's my line of treatment presently.
Okay, so it's a good combination, and that Peace trial I think had pretty good results. Herb, can you remind us of the results on that Peace trial?
The results were quite good. The idea that I guess that you're collaborating this thing with both chemo and ADT and ABI at the same time is showing better results than just using them sequentially.
Mm-hmm.
So there is good data there.
Yeah. So he's guiding you the right way, especially if he's not a specialized GU med onc, but that doesn't take away from the fact this field is moving so quickly that you really want to be with a GU med onc who is with a medical oncologist who specializes in prostate cancer, if you can, possibly can.
Okay.
If not, you want one on your team who's going to work with your guy.
Yeah, I'm definitely open to getting more opinions for sure.
And I'll look. If I don't look, I'll email you who we know from Sideman. There's definitely, it's bugging me now. I got to look. Sorry, you'll have to hold on a minute. Let me see who I know from Sideman. No, that's not it. It's not coming up. It's SEIDMAN, right?
SITEMAN.
Oh, SITE?
That's correct. Siteman.
Siteman. Okay, let me see. Well, one of my guys will look and see if they find a GU med onc at Siteman. But if not, let's think where you are. You're in St. Louis. Nordquist in Omaha. I know it's not close, but it's relatively close, and he's good. He's really good. He's the guy that's running a couple of these lutetium trials, and I've heard him speak. I heard him speak at PCRI a couple of years ago. He's definitely a really good name.
What's the first name on that?
Luke, Luke, Luke Nordquist.
Mm-hmm.
And he's at urology. I think it's Urology Associates. I had it open just a sec. Yeah, no, I had it open. Maybe I shut it. But he's at Urology Associates. Let's see. I'm trying to think who else.
I mean, I'm not that far from Mayo Clinic. I can go to MD Anderson. My eldest is working on their PhD in Boston, so Dana-Farber's an option too.
Oh, okay. Well, Mayo doesn't have great folks in Rochester, but they have a couple of really good guys in Phoenix. That's in our view.
Yeah.
And they could be people that will disagree, but that's our feeling. So Dana-Farber, you've got some really good choices. Where did you say your eldest is doing? At MD Anderson?
No, in Boston. So Dana-Farber's an option for me. Yeah. Mm-hmm.
Yeah. So yeah, we've given you a few names. We've put out a few names already there.
Right. I wrote those down. Thank you. Mm-hmm.
The other guy, Dana-Farber, he's a bit of an academic, but he's really, really good. Hold on one second and let me just pull up Dr. Bill, B-U-R-H-A. Len, do you remember that guy that was the guy that was working on the trial with Bill, who was using Bill's research? Do you remember the guy? Chowdhury, C-H-A-U-D-U-R-Y.
C-H-A-U?
U-D-U-R-Y.
D-U-R-Y. Okay, Chowdhury. Okay.
Chowdhury, he's good. Sweeney's good. Ellie's great. Alicia's awesome.
Mm-hmm.
She's awesome. And I
Ellie,
don't think
you said was the name? Ellie? E-L-L-Y or?
E-L-I-V-A-N-A-L-L-E-N. Ellie Van Allen.
Ellie Van Allen. Okay. Okay, I got him.
You'll see him he's on our advisory board. You can click on him. You can read about him on our advisory board.
Right.
Okay. Alicia is awesome. And she doesn't have a big patient load because she just moved from Northwestern to Dana-Farber starting September 1st, I think.
Oh, cool.
So you may get, and we've got guys here on the call who saw her there, and she's also in charge of the survivorship program there.
Mm-hmm. Nice.
So we like her a lot.
Mm-hmm.
I'm trying to think. So tell us, how much chemo have you had so far?
6 rounds. He said he'd give me 6 on the chemo, and we would hold at that and continue on with the ADT and the I'm going to say it
abiraterone.
wrong. Abiraterone. Yeah. Mm-hmm.
Yeah, Abby. Just call it Abby, Vic.
Okay. Thank you. That makes it easy.
We know what you're talking about. So when did you you were diagnosed in May? When did you start your chemo?
Started that early in July. I actually delayed it because my son was getting married in June, and I didn't want to be dragging through the wedding. So I waited till that was over with. And yeah, thank you.
And how are you feeling from the chemo?
Wiped out. Glad to have that 6th round behind me now, or almost behind me.
Have you been doing any exercise?
I've been trying, and and now that I'm getting past the chemo, I'm definitely going to, as I gain more strength, I'm going to be forcing myself to do more.
Well, who is going to talk to Vic about how the chemo might have been easier if he'd have done exercise during the chemo?
Too late for that.
Take that one on?
Too late for that, Rick. It's done. Let's move on.
I know, but we want you to know that chemo exercise will help you anytime. Who wants to do the exercise talk?
You also need to be considered for ADT.
Go for it. Go for it, Jimmy.
I always do. I always do. Yeah. Like, all I'm going to say is, of course, it's too late for the chemo for you to exercise during the chemo. But what I would say to that is there may be many things down the pike that knock the wind out of you. And when they do, that's the time you intervene. Before, during, and after. You will be glad you did. I won't go on, but I believe strongly that the reason I was able to basically sail through a bunch of stuff, including chemo, is I never let up on the exercise. Never did. It's so worth it. You know it is. Don't wait until you feel better. That's all I would suggest.
No, I'm already pushing myself, and I'm gaining my strength back from where I was. But I'm a believer. I know that everything I've read, everything I'm hearing tells me I gotta force myself to get out there and move and do more, and I'm gonna.
I will add to the anecdotal evidence that I started chemo. I'm about to do my third of cabazitaxel. I don't know if I heard what you're doing, but I'm on the elliptical now because whenever I feel like it or almost feel like it, I do it because the problem is the ignition, not the motor.
Yeah.
It's really hard to get started.
Yeah.
It helps a lot. So good luck with getting back into it.
Thank
one
you.
of the other things to consider over the next maybe 6 months or so, and to open discussion, is also treating the primary tumor. Have you had any? Have you had any? Read anything about that or heard anything about that?
No, I haven't. Basically, was focused on this current protocol. Seemed like it's highly effective, and what's really holding my interest right now is the Lu177 and where that's heading.
Right. So
have you had any genetic testing?
I did. Yeah, I had genetic. It's all neg.
And did anything come out of the genetic testing? Did it indicate any mutations?
No, negative.
Negative. And Henry, you need to get some genetic testing underway, probably from your tumor, from your recent tumor, or from a blood even from a blood test right now. You do need to look at it, and if you've got any, well, I'd start with that, and then we'll help you. We'll navigate you from there. There's a lot of evidence. I don't want to say there's a lot of evidence that there's a change in the way that we treat metastatic prostate cancer now. We never used to treat the primary in the interest of doing no harm. And we now believe, and I don't know the evidence behind it, but I know that Herb could quote it, but we now believe that treating the primary tumor makes a big difference. And probably for somebody like you with radiation, and there's a bunch of men who have had subsequent treatment to their primary after they did chemo. And it is a discussion that should be opened with your docs. So I just wanted to mention that.
Okay.
Anybody else want to say anything to Vic?
Any studies you can point me towards on that? What you were just mentioning?
Herb, do you know? I'm sure you researched this before you did your.
Well,
primary.
no, there weren't any studies when I did it, but there is a recent paper by De Bono and company that actually shows a survival benefit from irradiating the prostate, mostly in the face of low metastatic burden. But you never, I mean, there still could, the error bars are big enough to say, well, even with higher, you might have an effect as well.
Any studies ongoing I should be watching on that?
Well, I think there are right now, I think there may be a follow-up to that, but I'm not sure. I can't give you a clinical trial number, for example.
Here's what we can point you towards, and I've got references on this. Memorial Sloan Kettering did a bunch of studies on this in around 2014, 2015. And the studies were okay. There were some flaws in the study. They came out with a benefit of about, I think from memory, something like 24 months deferral on radiographic tree progression. And it was published at the time. The other people that have done this for years are Mayo. They've long believed in it. But it's picked up steam hugely. And those were both surgery. Those were both for radical prostatectomies for men with metastatic disease. What we've seen happen in the last 3 or 4 years is much more extensive use of treating the prostate with radiation therapy. Most of the guys on this call, if they've been treated metastatic, have done radiation therapy. We've got one guy who did surgery. I personally wouldn't do surgery because I think you're putting yourself through an additional set of comorbidities that you don't need really to deal with. But the idea is really to treat that there's a benefit from treating the primary.
Right. So that's one of the reasons I'm kind of focused on the Lu177. It seems to me like that's a radiation treatment that treats everything, not just the metastatic, but the primary as well.
You know, there's a lot of guys on this call who are looking the same way, and it's not easy to get into a trial right now. That's why I'm really excited for Henry, because that Jacksonville trial, he fits that bill perfectly, and it just might be a way to get in. They're looking for people in that trial who haven't done chemo, haven't done hormone therapy. They want to see what happens when they give it you early on.
Yeah, that's great. That's what I want to hear. I'm glad they're doing that.
For you, unfortunately for you, it's too late because you've already done some treatment.
Yeah, it's all right. You know, I hopefully I have 4 or 5 years here to wait it out until Lut gets approved in the U.S. and gets covered by Medicare.
We think you will, and if you keep coming back to this group, we'll make sure you do, or we'll do our best to make sure that you do.
I appreciate it. Yeah, and I want to thank all the regulars who deferred their time tonight, so newbies could speak. Appreciate it.
Vic, do we have you signed up for our reminders yet?
I'm not sure. I'm going to have to find where to do that.
Okay, so all you need to do is put your email in the chat window, and we'll sign you up. Okay?
Okay, sounds great. I appreciate it. Thank you.
And one thing I want to do right now is to give a plug to all of you guys on here for Speaking Freely, which is a really great call that we have once a month on the 3rd Thursday of the month. And it's a men-only call, and we talk about everything except treatment. So it's a great chat. It's the guys that attend it really like it. Moderated by the man I'm going to go to talk to very soon. And I'm going to sign both Vic and Henry up for that call. If, by the way, you don't want to be receiving email from us, if you unsubscribe, you'll get unsubscribed from everything, including the reminders for this meeting. So you have to go in and read carefully at the bottom, and you have to go in and pick what you don't want to get reminders on. Okay,
Rick,
I'm gonna,
Rick,
yes.
before we move on, I don't want to bring to Vic's attention, I put in the chat box a link to an article showing, talking about the benefits of treating the primary and metastatic prostate cancer.
Oh, thank you, Len. Okay. Thank you, thank you.
You're welcome.
Great. So I see that it's just a couple above yours, your email, and if you click on that link, it's live. It'll open up in your browser. So the other three guys, I'm sorry, we've just got to try and get round our guys. If you hang in and you want to talk at the end, I will stay on as long as it takes. If anybody wants to stay on, I'm here to listen. But we've got to get through to some of our guys, and I'm going to start off with Rich Jackson because I encouraged him to come on tonight and to bounce his situation off of the group. Mr. J, are you with us?
I am. A slight aside, 4 of the 5 gentlemen have been added to the high risk speaking freely. I've got 1 for the under 60, which was Henry. Do not haven't seen the 5th gentleman's name and email address yet.
Okay, well, thank you for taking care of all of this, but this is about you. We know you don't like to talk about you, but I think we have to because you've got some issues going, and I want to get the benefit of the brains trust here. And in case the rest of the group didn't realize, Rich Jackson is one of our very hardworking and very committed volunteers to whom we are very, very grateful.
You say that to all your girlfriends.
I wish I had a few to say it to, Rich. Bring this crew up to speed, please.
Gleason 9, radiation treatment in 18. PSA started going back up. Had a clinical trial PSMA scan in 20. Located 2 sets of lymph nodes. The PSA was up to 5.1. Prior to this PSMA scan, had radiation treatment to two different sets of lymph nodes. At the immediate end of radiation, PSA dropped to 2.2. 5 months later, it dropped to 1.7. 3 months later, it was up to 2.5. About 4 days ago, it was up to 4.06. Had an Acumen scan on the 25th of October. Identified two other sets of lymph nodes, one in the periaortic region, center of the chest, sort of wrapped around the periaortic artery and near the spinal column again. The other was in the neck. No bone issues anywhere. Had the scan from, as they phrased it, eyes to thighs. Nothing lit up except those 2 sets of lymph nodes. At the moment, the radiation oncologist I had that did the initial shot on the lymph nodes is no longer in practice. So I'm looking for an RO. Rick wants me to find a MO, a GU oncologist. He wants me to start ADT, and he's pushing chemo quietly in the background. He's attempting to destroy what life I have left.
I have to deny all of the above. All I'm telling him is, if it were me, I'd be thinking about systemic treatment. We can't keep nailing this with spot RT. Is that fair?
You're in Arizona, my arms are too short. I'll let it slide.
Yeah, I would say I made that mistake. I tried spot radiation on a couple of metastases. It worked for about 5 months, and then it went in completely the other direction. 2018. I'm now doing.
Rich, I have to agree with Rick. As much as I don't like to agree with Rick, I have to agree with Rick. This, you need more than just radiation, because it's the chances of it being somewhere is too high.
It doesn't make sense to me, Rich, that with just 2 lymph nodes, which is all they saw on the Axumin, that your PSA is up to 4 plus. What? Remind me, when you were first diagnosed, what was your PSA?
The initial diagnosis in 17 was 13.8.
And you were 4 plus 4?
4 plus 5.
4 plus 5.
And
So-
5 plus 4. 9.
So you're not a guy that makes huge amounts of PSA. I mean, relatively normal. And if you're back up to that 4 level right now, and the Axumin only sees 2 lymph nodes that are active, something else is going on. It just doesn't sound like. It sounds like 2 lymph nodes. That's too much PSA. I mean, that's just a gut response. You know, we don't give medical, but that's my gut. What would someone else say about that?
Yeah, I agree with you, Rick, and Herb that definitely Rich needs systemic treatment if he's not too keen on chemo. Maybe you can get into that Lutetium-177 trial that Rick posted.
Oh yeah.
Provided you haven't had more than 2 years of ADT. I think it was a bizarre set of inclusion and exclusion criteria, but you could either be completely hormone naive, or you could have had 2 years up to 2 years of hormone treatment, followed by at least 1 year of drug holiday from ADT. And I think you were still eligible. So take a look at that trial that Rick put in the chat box, Rich.
Yeah, Rich, that might be perfect for you, man. The only problem is where it's at, which is Jacksonville. But that said, I forget. I think it was it 6? Was it 6 treatments of lutetium, Len? Do you have it open?
No, I don't have it open.
Okay, but
that's the typical treatment.
But the other thing with that, also, Rich, is that we can hook you up with Lazarex, who are there to help you with travel and accommodation on clinical trials. And Jerry Deans is talking to them right now, and they're wonderful. And we have a great relationship with them. So even there, we could help you. So so the Jacksonville part shouldn't be a preventive. But do you see where I put it in the chat window, Rich?
Looking at it now.
Great. Okay. So you'll call me and we'll talk about it. But is there anybody else that would like to speak to Rich about? You know, he's. It's not a secret. He's always been very reluctant to go back on hormone therapy. When did you stop, Rich? I can't remember.
2018 was the year that didn't exist.
Okay. So you're more than 2 years out, so I think you're good for that trial.
I had 14 months. October 17 to December of 18.
Yeah. Okay, well, again, we got a lot of guys to cover, but I just want to make sure, is there anyone else that wants to say anything to Mr. J?
I
Rick,
think you said it.
I checked the trial. It is 6 cycles. 6
Right.
cycles of lutetium. Yeah.
But it's also the case that the other arm is ADT.
Is it randomized?
Yes.
Well, it's open label and it's crossover. So even if he gets into
Yeah,
the
that's
wrong,
right.
Right.
wrong
Yeah, it
arm,
was crossover. That's right. I remember reading that.
Yeah.
Yep,
Crossover.
crossover.
yeah.
Okay.
You know what we mean by crossover, Rich?
Don't know the book definition. My initial assumption would be that after a certain period of time, I either have the option of crossing or they force a cross.
No, it's always your option. Always your option to switch to the other arm, which of course would be the lutetium arm if you weren't in it to begin with.
So
Right. That's correct.
so take a good look at that, man. It might be a good one for you.
Okay.
Okay. All right. So I'm going to keep moving along here, if we may. Just make sure no one else has anything for Rich. I don't want to shortchange him. He never shortchanges us, so I don't think we should shortchange him. Okay. Frank Fabish.
By the way, I would say the other site they're doing that trial is Paris, if you really want to go for it.
Not sure
Brenda-
what their
Brenda
COVID
might like that.
limitations might be.
Hey, listen, but Brenda might be all in for a Paris site. What do you think? Okay, Frank Fabish, you wanted some time tonight.
Yes, just a little bit. Everything's going well. I'll see my doc back in January for the next blood draw and checkup. But I'm on two chemo drugs, the Orgovix and enzalutamide. And I was starting to run into some problems of side effects with the enzalutamide. So my doc took me off of it for 2 weeks. And then he started me back on Tuesday of this week with 2 pills instead of 4. And I'll go to 3 pills next Tuesday. And then I'll stay at 3 instead of 4 to see how my system reacts. The main problem with the side effects has been the increase in the frequency of hot flashes and stomach issues, unsettled stomach, and it really is limiting the amount that I can consume at any one time. So my question is, I know that there's 2 other similar drugs out there, apalutamide and also darolutamide. And I wanted to see the experience that others have had with those 2 drugs in comparison to enzalutamide.
Who's anybody here done both enzalutamide and one of the other ides? It's kind of unusual to find that, Frank. Oh, go ahead.
I was on enzalutamide for 30 months and it worked quite well for me. Then I went to abiraterone and then I went to apalutamide, and neither the Abby or the apalutamide did anything for me. But I had developed an AR mutation by that time. I don't know if that's helpful or not, but yeah. So
what is an AR mutation?
Androgen receptor mutation. After some people, after a period of time that they're on these second-line anti-androgen drugs, develop a mutation that makes you no longer susceptible to the drugs. And that's what happened to me. Abiraterone didn't work for, only worked for a month or two. Apalutamide didn't even work that long. But
Got it. Thank you.
Yeah. You're welcome.
Jake, did you see any side effects that were different between apalutamide and Enza?
No. I've been fatigued since I started on ADT back in 2012. So all they did was add a little bit more to it, but I didn't have any, serious hot flashes or, no nausea, nothing like that. Just maybe an additional bit of fatigue for me.
It's pretty unusual, Frank, for men to change from one eye to another, other than to darolutamide. And we've had some guys that have gone to darolutamide, but darolutamide is a somewhat different drug. And we know that it has lesser side effects, but usually related to issues around fatigue and cognition. We've had guys that have gone from abiraterone to an IDE, or an IDE to abiraterone, like Jake and Len. But the stomach issues, the fatigue is what we hear mostly. The stomach issues are less common. Has anybody had stomach issues from being on an androgen receptor blocker? Anyone else?
I've been on enzalutamide for a year and I've had stomach issues. I think I mentioned that a few weeks ago to Frank.
How are you handling them, Jim? And
I'm a little more careful with my diet, so that's helping a little bit. And then I also backed off the enzalutamide with my doctor's permission from 160 milligrams to 80 milligrams a day, and that's helped a lot. Helped a lot all the way around with the side effects, the hot flashes, the fatigue, the mental fog, all that, and the stomach issues.
Have the stomach issues improved since you stopped the enzalutamide, Frank?
To some degree, they did go down, but I wasn't off of it for that long. It was only 2 weeks. And I don't know how long it takes for that to get out of your system in 2 weeks' time.
I think the half-life of enzalutamide is just a day or two, so it gets out of your system pretty quickly. I specifically had that discussion with my doc.
One of the things I'm wondering is whether this stomach issue could be left over from your chemotherapy.
It could be. My appetite, even though my taste has come back, my appetite and the ability to eat enough at any one time has stayed with me throughout the period of time. I ended my chemo sessions towards the end of April, and for the most part, the side effects from chemo were gone in around 2 to 3 months, which put me at the end of summer. But the issues of the stomach continued. So again, I
have
don't
the-
know if there's a solution or not, but I'm going to have another discussion with my doc this week to explore what he thinks about it, and if he has any different conclusions.
So one of the things I'm thinking to raise with him is whether this has anything to do with the enzalutamide at all. I mean, I think the hot flashes may do, but whether this stomach issue has anything to do with the enzalutamide, if this is something that's a continuation of a side effect from your chemotherapy, if it has never really ceased since chemotherapy.
Yeah, again, I think that's a valid point to raise in the discussion with the doctor.
Okay. Anybody else have any other thoughts on this? Was that Dr. John?
Yeah, I don't really know, but aren't you supposed to take enzalutamide with food? And if so, do you?
I take it after meals, yes. Right after I'm done eating, I take it, not before, not during.
Frank, do you take metformin by any chance?
No.
Okay, because that can cause stomach issues also.
Yeah.
No, I'm on Lantus for diabetes type 2.
Okay. Well, we've given you a few things to discuss with Dr. Oh, his name is on the tip of my tongue. Monty. What is it?
Mortasavi.
Mortasavi.
Yes.
Mortasavi. So we're given a few things for you to talk about with Mortasavi. I do want to mention something else unrelated, and I'm putting it in the chat window right now. Tomorrow, starting at 10 o'clock Eastern, 7 a.m. my time, there's going to be a very interesting webinar or presentation, really, on cachexia. Cachexia is a response we see fairly often in advanced cancer, where essentially you cannot consume enough energy from your food, and so you lose weight. And this Cachexia Conference tomorrow with the Cancer Support Community, CSC, is also involves the FDA, and it is a direct patient feedback session for the FDA. So if you had any experience with cachexia, either as a patient or as a caregiver, and you have anything that you want to voice on treating cachexia, this is a good session to attend, and the registration link is right there. I am going to be part of a panel for about an hour and 20 minutes, starting at around 1:30. Yeah, 1:30. Yeah, Eastern. Sorry, I'm translating times all the time in my head. So I did want to bring that up. All right, we're going to move right along. Ted Healy.
Hey, Herb, Rick, everyone. So I had my PSA. So far, no evidence of disease, thanks to Dr. Lovely Julie Graff. I'm also participating in a study that you might find interesting. It's a remote, what is it here? Remote mobility assessment. I'm wearing ankle bracelets, monitors. I think probably the most interesting thing was it included a 2-hour assessment that provided a what's called a DXA scan that's measuring my muscle fat and bone content, as well as I was strung up with electrodes to do that as well. And then it was a pretty thorough assessment. I'll be wearing these sensors, ankle monitors for 7 days. logging the date, the time I put them on, and the time I take them off, sending it back to OHSU, and then they'll be sending me a full report. So I just wanted to throw that out there.
Wow. Now,
Did you get the socks? Did they
Yes.
give you the special socks?
Yes, the special socks that light up when I get close to schools. No, just kidding. But yes, it's the special socks. It's pretty cool.
What are the special socks, Professor?
These are they called me to be part of this trial, not realizing that I was on the East Coast. So I
Here,
learned about this stuff
I'll,
before they turned me down.
I'll show them. I don't know if you can see them, but it's on. I don't know if you can see that. Well, that's my puppy. But that's what they look like, both the left and the right. And the actual sensor is on the side here, and it lights up to let me know it's working. And then I plug it in at night, it turns yellow that it's charging, and then I mail it back to them, and then they'll send me the results. So yeah.
Now, what is the purpose of the study?
The purpose of the study, as I understand it, is to look at the potential effects of gait and Lupron. It's on Lupron patients. You had to qualify if you've been on Lupron 6 months or more. And I can read to you.
They have an arm for gait and they have an arm for balance.
Here it is. Treatments for prostate cancer can cause side effects such as fatigue, muscle loss, and weakness, which can increase the risk of falls and frailty. People who do not take part in this, who do not take part may receive recommendations such as encouragement to exercise and/or ways to adjust their daily activities to help combat some of the physical side effects of cancer treatment.
Cool.
This is an ancillary study to a exercise program they're doing that includes there's 3 ways you can participate: yoga, strength, and flexibility. And you're assigned randomly one of those 3 things, and they track you for 6 months.
Wow. Well, I mean, I'll tell you one thing from my own personal experience. I mean, my balance was never good, and I am certain that the Lupron, that 2-3 years of Lupron made it worse.
Ditto for me too, Rick. Yeah. I mean, they make you, stand and hold your leg up and watch how you teeter totter back and forth. And that's always been an issue for me. And it's particularly, thank God it was in a basement where no one was around, because it was very, not humbling. It was very humbling. So
I know.
They were great guys.
It's embarrassing.
They were very,
It's and the funny thing is, most of you know I'm a rower, and I row a boat that's 11 inches wide. So my balance in the boat is pretty good when I'm sitting down and trying to balance that boat. But I can get out of that boat and fall over right away. So, my standing balance is horrendous. Horrendous.
Yeah.
Oh boy. Okay. Well, that's really cool. Well, you'll have to tell us how you do and what it uncovers. Who's sponsoring this? Is this a Movember?
OHSU. The doctors. So the primary investigator is Carrie Winters Stone. Dr. Tom Beer, of course, is involved in it.
Yeah.
He's the co-investigator. The project director is Deanna Tibbetts, and then there's an ethics committee and oncologist on call. But those are the primary people driving it.
Well, good for you for participating. Really good for you, Ted. I just sent somebody to. I gave them a bunch of names at OHSU, including Julie Graff. They needed a doc in the areas. Genta was on the call last week from Oregon City.
Yes.
So sent him over there. Okay, we're moving along. Anybody else have any questions for Ted on this study before we move along? Okay. George, you're up.
Thank you, Rick. Rick, I was wondering if the group had discussed adding Abi and prednisone to ADT for patients who are not metastatic, high risk, non-metastatic?
This is very topical because I think it's being discussed right now as a new mode of treatment. Has anybody considered doing ABI before they are clearly metastatic when they're high risk?
Rick, I put a link in the chat. It's a video actually. Dr. Alicia Morgan's interviewing Dr. Gerhard Attard in London, and it's the Stampede study. And Dr. Morgans and Dr. Gerhard both conclude at the end of the interview that this should become the standard of care for high risk non-metastatic treatment. So I just wondered if
maybe
it
that's
was
where I
discussed here.
saw it. Maybe that's where I saw it, George. And Henry, if you're still with us, there you can, and both Henry and Vic, you can see Alicia Morgan's in action in this video.
She's very good.
She's great.
Hey, Rick.
Anybody? Yes.
All of the lutamides have been shown to, extend survival in non-metastatic castrate-resistant patients, and some in hormone-sensitive prostate cancer that was non-metastatic. And yeah, ABI too. So, I mean, all of them have been proven to extend PFS and overall survival.
What I was going to say is I started on the relugolix and just last week added ABI.
Well, that's interesting.
Based on Dr. Eaton's recommendation, actually, and my buddy Dr. Dan approved, concurred.
Oh, that's interesting.
Non-metastatic.
So Dr. E recommended that, and Gainesman agreed, huh?
Yes. And she did it based on the fact that she was one of the reviewers on the Stampede trial.
Okay. So guys, again, we were talking before about Dr. E and why I like her, because I think she's very forward-thinking and flexible, and how you can get your doctors to work together, which is what Joe's done. Joe has kept Dr. E in the loop, and he also has a very good GU med-onc at Fox Chase, and you can get these docs to work together. So George, remind me, George, where you're at?
I'm at Georgetown University, and I saw Dr. Collins today. I had my last radiation treatment today.
Oh, great.
And the interview with Dr. Collins, I asked him about it, and he said that, it's not his field, there's silos, but he would not be against me going on that. And the day after tomorrow, I will see Dr. Paul Legere at Georgetown. He's my GU medical oncologist, and I will ask him. I've already sent him a note, and I've sent him the link to Dr. Alicia Morgan's interview on that. So I'm looking forward to discussing that with him on Wednesday. And he's pretty good at going along with what, working with me so far. So we'll see what he says.
We can definitely, how do you spell? Oh, Legere, L-E-G-E-R,
Legere.
I see it.
Mm-hmm.
We can definitely connect him to Alicia or to Eleni. If he wants to talk to them in person, we'd be happy to facilitate that.
Okay. So like I say, I sent him the link, and Dr. Sean Collins knows Alicia. So
okay.
I think everybody in the field probably knows of her. But the other thing I wanted to mention before we go on this, I have to really thank Jim Marshall, my friend, who was on this chat. He's probably still there, because he was the one who suggested to me to look into this. And I'd always thought it was for metastatic only. So I did my research, and thanks, Jim, for alerting me.
Thank you, Jim.
Okay, Guy. I thank you very much.
Not just a pretty face there, eh, Mr. Marshall?
I try hard.
Okay, thank you, guys. I love it when you guys work together because two minds are oftentimes better than one. Well, George, keep us posted, and I hope it comes out. And the fact that Joe is doing this is also, you know, you can mention that Dr. Gainesman and Dr. Staci are working together with one of the guys on AnCan.
Okay, where are those doctors?
Dr. Gainesman is at Fox Chase, and Dr. Staci just moved to Houston Methodist. She was 14 years at MD Anderson up until October 1st.
Okay, where's Joe?
Where's Joe? Joe's in Bucks County, right, Joe?
Oh, Bucks County. Beautiful.
Joe, speak up, Captain. You're muted. You're muted.
Yeah, I just got on mute. You know, that's all. I'm trying to avoid that. Yeah, Bucks County, just outside of Philly.
Thank you, Joe. Where are you being treated?
At Fox Chase Cancer Center in Philly.
Fox Chase. Okay, thank you.
Northeast. They're an NCN and NCI facility. So when you look them up, they're an NCI,
Okay,
one of the major ones.
Okay, thank you. Thanks, everybody. Thank you, Rick, for moderating and all the co-moderators.
Well,
and all
George,
the
I'm
guys
going
out there.
to be wanting to match up with you, you know, on our sessions as we go along, so that we can share whatever.
Okay, great. How long have you been on it, Joe?
Well, I've only been on ADT since July. Started off with the Ergovics and just added the abiraterone last week.
Okay, good. So we might be running parallel beside each other, side by side.
Yep.
So what you should know, George, is that Joe thought he could do active surveillance and then suddenly discovered that he had a little spot of 4+5.
Mm-hmm.
So he had to rethink.
Yes.
And
that happens.
That happens. And I am putting, George, drop Joe a line so he has your email. I've just put his
okay.
email address, joeg@ancan.org. Joe moderates, Joe leads the active surveillance moderation team, and he's also part of the low intermediate moderation team.
There's my email.
There you go.
Thanks again, Joe. And
George, got it.
All right, you guys can communicate with each other. Okay, Joe Murcia. Yes.
Rick, sorry. I'm with Dr. E, and she started me on the Abby last week with dexamethasone, a 0.5 milligram
that's
tablet.
Right. Another one. I forgot, Julian. You're right. Another one.
And I thought you had a better memory.
Yeah. I got too much going on this week.
Yeah.
And you're not.
Actually, I get an MRI tomorrow.
Now, Julian, did you have any involvement with your lymph nodes? I can't remember.
No, nothing.
No. Okay.
Only in the prostate, and it was a 4+5 for Hopkins.
Right. So there you go, George. There's another one.
Good. Where are you being treated, Julian?
With Dr. E at Houston Methodist.
Okay.
I'm in Houston.
Okay, good.
So George, can I ask, George?
Yes.
Can I ask you a question again? So what was, they were going to give you Abby and what?
So they weren't going to give me anything. I just found it. I mean, I did my research. Okay. I saw the Stampede study. Dr. Collins said he's not against it, and I'm going to talk with Dr. Leger, the medical oncologist, day after tomorrow.
Okay. Anyone else for Joel?
Rick just mentioned that Dr. E is also in the was it ESMO, which is the European oncological group.
Okay.
So you get a cross blend there as well.
Mm-hmm. I think the Stampede study is European, Switzerland, and UK.
Yeah, like I said, he was one of the reviewers on that.
Okay.
Okay, I'm going to keep moving here. And next up on my list is Joe Mergia. Can we hear you now, Joe?
I don't know. Can you?
Yes.
Okay. Had a PSA last week, and it's gone up about 10 points from mid-20s to mid-30s, which it hasn't done except if I've taken a vacation, which I have not. So we're thinking about, we're going to get a CT scan to see what we see. And then we're talking about Eligard or Firmagon, possibly. Now, if you recall, I know you do, I was looking at that nutritional clinical trial, and they haven't gotten back to me on it. And I need to be in a PSA stable or rising, not a PSA falling. So if I took one of these antagonists, I'd be falling, hopefully. So I'm in a kind of in a quandary. So I'm going to try and get the people at Stanford to hurry up and see what's taking so long to get my acceptance. I've done everything they've asked, but haven't heard back.
So, Joe, I think this is telling you something else that you probably don't want to hear. That since your cancer's on the move, the nutrition study is not going to be strong enough medicine, even if it works. And that's what you've got to deal with, because, you know, you're in a similar, somewhat similar situation to Rich Jackson, in that you really don't want to do hormone therapy. You feel quite strongly about that. And so you've been casting around, what can you do other than hormone therapy? And the nutrition study was a possible option when your PSA was stable, but your PSA isn't stable anymore. When was the last time? I have a note that your PSA was steady at 29. I don't know when that was, and give me some idea as to how long it is since you last tested and now that you're in the mid-30s.
I think my last test was June.
Okay.
And it was stable then, and now it's, as of last Friday, it's gone up.
To 30 what?
I think it's 38.
Okay.
Is one test enough to decide it's going up? I mean, it shouldn't be taking another one in a short while to see if that could have been a false reading.
Well, we're going to get the CT scan and see if that shows progression.
Well,
then
you know, another thing I'd say to you right now, Joe, is to be pushing for something better than a CT scan, because it's covered by your insurance, and you could get an Axumin scan, or better still, Axumin is AXUMIN, Axumin, and better than that, you could get, which is a type of PET scan. better than that, you could get a Pylarify scan, Pylarify, Pylarify. And both of those are going to give you a better result than just a CT bone scan. And I would strongly be pushing for that if it were me. So we know what's going on with you.
And another thing, Larry, I can't understand is with the cost of a PSA test so low, why aren't you doing monthly, or the doc willing to do monthly PSA and create a graph and track it to really see what's going on?
Well, it's as long as I've stayed on the Casodex, it stays steady, and when I go off it, it goes up.
Yeah, but eventually the Casodex is going to fail, and then
Well,
it's going to start
that's
shooting up.
That's what we're thinking. I mean, it only ever came down to the mid-20s.
Yeah. All right.
But
My suggestion is, why not just get monthly? It costs $10, $15 to $15 a month if you buy it yourself, I think. So that they should definitely. 4 months seems like a long time. I don't know. It's just my feeling. I'd be very nervous if it was 4 months.
I mean, Larry, if things are stable, then 4 months 3 months isn't so terrible, right?
But didn't it go from 29 to 38?
Yeah.
In 4 months.
Yes.
Yeah. Well, it's not.
And when was that PSA, Joe?
Last Friday.
Uh-huh. So
I would want to take one at the same lab and get a confirmation, because there are other things that could affect PSA: time of day, what you ate, what kind of exercise you had. I mean,
I'm not going to jump on further ADT until we see what happens. But
Rick's recommendation of getting the Pylarify, which is a PSMA PET, is probably really a good one, and it is being rolled out in a lot of facilities now. They're all, all the major ones, or most of the major ones, are implementing it. So you really ought to look into that, and it is covered definitely by Medicare, and it's a lot of the insurances are now signing on.
Yeah, I just remember.
Joe, hold on a second, Larry. Yeah. I'm not clear. Are you on bicalutamide now, or are you not on bicalutamide right now?
I'm on bicalutamide.
You are?
Yes.
Okay. But you're not on the Eligard. I mean, my feeling on that, if it were me, is if I was going to be on a single drug and didn't want to be on Eligard,
right,
I would be on enzalutamide or abiraterone, one of the IDES or abiraterone. If you're going to be on one single drug, then you're better off for it to be one of those IDES based on the evidence that we've seen in this group.
So, Rick, I guess that.
Hold on, let me just finish, Herb, and then I'll come to you. Len's been on darolutamide now for 20 months. Peter's been on monotherapy darolutamide for I don't know how many months. Ken's been on monotherapy. Well, it's not really monotherapy because he's doing chemo too, but he's only been on abiraterone. So we're seeing good results from monotherapy, but a stronger drug than Casodex, bicalutamide. Go ahead, Herb.
Well, I mean, my own sense is that the effects of a single drug, if you're picking Abi or, for example, Lupron, I'm not sure they're going to see a big difference in side effects.
That's what I'm thinking. I don't think I have too much to lose. Maybe hot flashes if I go to one of those drugs.
Right. So, but I don't know what the hesitation is.
There is none now. I think maybe I wasn't clear at the beginning. This is the first time I've seriously talked with the doc about taking one of them.
Okay,
Good.
you need it.
We're on board. We're on board with you, Mr. Merger. Now, also, let me tell you, right now, the EMBR Wave trial is still open. They still need about 4 or 5 more people. Okay, so you could sign up. The problem is you haven't had the hot flashes yet, have you?
Well, I have some, but they're probably not what Lupron will
Don't
give
say
me.
that. We didn't hear that. Okay,
Okay.
we didn't hear that.
Okay.
So as long as you tell them you've had a few hot flashes, you're in with a chance of getting an EMBR gizmo, and you're probably going to need it if you go on the abiraterone or the
Yeah.
or the Eligard.
I thought about that.
Okay.
What
Yeah,
do you think of?
I told him I didn't have hot flashes and I didn't get it. I had to pay for it.
Right.
How much was it?
Well, the list is $349, but they knocked $100 off.
Okay.
Well, Joe Gallo, if you didn't have hot flashes, why did you want the EMBR device?
I ordered it before I started ADT, figured I'd have that sitting on the shelf just in case. And the closest thing that I've had is very rarely, I would say, a little bit of tingling on the skin in a more stressful situation, but not really anything beyond that, and it goes very quickly.
And Joe Murgia, just, I don't know if you're aware, in about 1/3 of cases, when people stay on Casodex, the drug becomes a stimulant for your prostate cancer rather than a suppressor. So, and they actually find that if you stop taking Casodex, your PSA might go down.
Yes, I forgot about that. Thank you, Len.
Yeah, that's actually where I was trying to head when I was talking, is that my experience was that my PSA started to double till I stopped the Casodex. And I was doing relatively monthly PSAs at that time when it started to go up and then it started to double. And I really went up to point 3 something to 0.67, or maybe there was something one in between. And I'm glad I didn't wait a few more months and really, push that development. And then as soon as I stopped, it went back down to 2 or 3 and stayed like that now for I'm on Lupron for 5 years. So just I like to watch my PSA often, even if I'm even taking Lupron shots every 3 months. I want to get a PSA in the middle, watching it pretty closely about when to shift to a second ADT drug.
So, Joe, one of the reasons we really wanted you to add a GU medical oncologist to your team is for these insights, because they're going to know that. And we still think you should add a GU medical oncologist to your team. I forget, you're in, where are you? Pennsylvania, St. Louis? I forget, where are you?
No, Syracuse.
Syracuse. That's right. Okay. Well, we still think, oh, and there is a guy, there's a guy in
Rochester.
Rochester that we think is good.
Right.
So write to us if you want his name.
Okay.
Tracy Saville is seeing him. I forget his name off the top, but I just would
It's
have to
Van
look at
something.
Tracy's.
It's Van something, isn't it?
Yeah, but it is Van something. Yep. Van something. And Tracy really likes him.
Okay, maybe I'll look into that.
All right. All right, I'm going to tell you right now, because all I got to do is look up Tracy. I've got to look up Tracy.
Vanderwheeler?
No, Vanderwheeler is in Chicago. Hold on one second. Tracy Saville, Van Veldhuizen.
Right.
Veldhuizen. Van Veldhuizen. And I'd be happy to, if you write me, RD at AnCan, I'd be happy to connect you to Tracy.
Okay, good.
Okay, but we want you to get, we want you around, and we want to nail this. Okay. Now, for those, Vic, if you wonder what the heck we're talking about when with the EMBR Wave, it's a gizmo that you wear on your wrist. Have you heard about it, Vic?
Yeah, not specifically, but I've heard the term knocked around. Yeah.
Look in Dave Muslin's window, and you'll see he's got it on his arm right now.
Yeah. So that kind of relieves hot flashes from ADT. Is that correct?
That's correct.
The concept it uses is the same thing that when you're out in the snow and you come in and you grab a cup of hot chocolate, and all of a sudden it warms you up. Well, this does the reverse.
Oh, excellent.
If you can get it, if you can hit the button just as your hot flash starts, it will stop with this device. It really does stop them. That's wonderful. If you're a little late, you're going to get hot, but a little bit, but it will still stop it. And it's I take a Depo-Provera shot every 3 months to stop the hot flashes, and I'm gonna stop doing it. I have one due this month, and I'm not going to do it because the device works so well.
Jeff, don't you also set it for overnight?
Yes, well, I've got one button set for hot flash and another one set for overnight, for all night. And that way, if I happen to wake up, and it happens once in a while, I'll wake up and I'm not having a hot flash, but just as I'm waking up, I feel one coming on. So I can quickly switch over to hot flash. And I usually fall asleep and forget to switch it back. But the all night works quite well. I used to wake up 2 or 3 times a night, and now I almost never wake up with a hot flash. I mean, every 2 weeks, maybe 3 weeks, I'll have one. That's about it. By the way, I did a podcast with the doctor who works with EMBR, Pamela Peak, and I could put a link to that in the chat window so people can to listen to that chat. It's in a women's forum, a podcast group, and they talk about, yes, men get hot flashes too.
So I just want to say something to all you guys about hot flashes. Because you don't get woken up doesn't mean to say that you're not having hot flashes and your sleep isn't being disturbed. If you suffer from frequent hot flashes, the chances are you're being woken up multiple times in the night and you don't even realize it. And so I would say to you, leave that in the overnight mode, whether or not you're having a hot flashes or not, or you think you are, because it's going to give you a better night's sleep. You're going to wake up more rested in the morning. Right now, they're still looking, as of last week, Dr. Morgan's reported on this in the PCF conference, and they're still looking for around 5 to 10 guys to finish off the study. And if you qualify, you get a free gizmo. So check out EMBR Wave and just tell them we sent you. We've probably provided about half the guys to date. I think there are 38 guys to date, and they're trying to get to 50.
Okay, so you can sign up for that study via the EMBR Wave website?
Yes.
EMBR Wave. If one of the guys can find it, they'll put it in the chat window, the link for the trial. I can't do it right now, I'm afraid. Put it in, or email me and remind me, and I'll send it to you. I can find it quite quickly. We featured it in our reminders for about 2 months. We may start again because they still need a few more people. But we've got people other than Jeff Marchi who swear by it. But when I say other than Jeff Marchi, he's the big spokesman. He's our major man. But we got a bunch of other people who swear by it too. Okay. Keep an eye on that chat window, Vic, and you'll find somebody I hope will put that in. All right, we're going to Steve. Steve, what's up?
Okay. Most important, I have my third chemo, my third cabazitaxel infusion on Thursday. After the second one, I think I had really bad acid reflux, to the point that I was really coughing on Friday night and some extra mucus and whatnot. And I started taking omeprazole, I guess Nexium, that he prescribed for me, that I've always had an iron stomach. I didn't think I needed it, which was obviously wrong. And I've been hoarse for about 3 weeks now, which I think is the acid reflux. And it's gotten better over time. It's gotten better once I started taking the medication, but better is not great. I still cough at night and cough in the morning much more than I have in a long time. And I'm wondering if anybody else has had experience with that, with chemotherapy, or any comments on it. So that's one thing. Actually, Friday night, in the morning, I had a little blood in the mucus. It went away by Saturday night, Sunday morning, and it hasn't been back. So I haven't said anything. But that is really the question. I think I'm still tolerating it pretty well. I did an hour on the elliptical machine, which made this go by pretty quickly while watching and listening. Not at the fastest pace in the world, but it was just fine. It's good exercise. And at any rate, does anybody have any thoughts about? I don't know that acid reflux is a symptom of chemotherapy, but I guess almost anything can be. So
First of all, Steve, good on you, Steve, for doing the exercise.
It ain't easy, but I push myself hard.
We're proud of you, man. I think that's really good. That's really good. Anybody have any feedback on acid reflux?
So in my chemo rounds, the doc gave me dexamethasone, I think it was, around the time of the infusion. And one of the side effects from...
I'm sorry, go ahead. Yeah,
one of the side effects I had
with the chemo.
Yeah, so one of the side effects that's common with that drug is like an acid reflux. Like for maybe 5 days following, I'll get or would get hiccups of sorts, uncontrollable, just random, and if I had food in my stomach, it would act like acid reflux. I don't know if that's what you were experiencing, but that was one of the side effects from it.
I get a sort of a bronchial dark cough that can scares the neighbors, I think.
I mean, Steve, that sounds like a classic symptom of GERD.
Yeah, that's kind of what I thought. I'll ask them about it, but sometimes their answers are so complicated. I thought maybe somebody had a little bit of a thought process. So that is one thing. And one other thing I've been taking Degarelix, Firmagon.
Hold on. Is Ken still with us? Ken Anderson?
No, Ken left.
Oh,
Ken
wow,
left because he's the dexamethasone king, and
Yeah,
I wanted to know.
They give me, I think, 12 milligram infusion right before the chemo.
Yes.
So, I mean, I didn't associate the two, but, you know, when I was taking abiraterone and prednisone, they always told me to eat with it in the morning. And frankly, I never ate in the morning and I never ate till lunch, and it never bothered me one bit. But I guess now I have to eat 3 meals a day and small meals. And since I've been doing that, it's been getting a little better.
I don't know, Steve. I used it as an excuse for a croissant in the morning.
That's what I'm doing. You know, I'm eating cereal or a bagel or something like exactly. So I've gained about 10 pounds, I think, in the last month.
Yep.
You know, but
for
the moment, I'm not thinking about it.
Steve, Henry has just put in the chat window that he's been taking pantoprazole for GERD for 3 months, and it's been great.
Yeah, I mean, I'm on pantoprazole as well.
You know what? I'm not sure they didn't prescribe that for me, and I forgot about it. Okay, thanks. That's terrific. My laptop is far away. I couldn't see that, but I thank you very much.
Thanks, Henry.
Look into that. And other question I wanted to ask for any thoughts on is, I've been doing Firmagon now for 31 months. I don't really have any side effects. I don't think I think I checked my testosterone myself about 6 months ago. My doctor doesn't seem to be, it was negligible. You know, I don't know. Is that something that can lose effectiveness over time? Is there any value in switching? You know, all this time I'm doing fine with it, but I guess there are some side effects that build up over time. And every once in a while, I do have a little bit of an irregular heartbeat, which I think is one of them. And since I started all this stuff, my resting heart rate, which used to be 53, 54, is now 75, 77. So it's changing things, you know, but I would rather not change. But so far, I think there's small prices to pay. I feel pretty good.
So, you know, there's a bunch of questions rolled into one. I mean, the first thing is, we know that you're castrate resistant right now.
Yes.
And given the degree of castrate resistance, it's unlikely that switching the LHRH would make a difference. Although for some people where they're just starting to go castrate resistant, we've seen it happen where they've gone from one LHRH drug to another LHRH drug, and it's helped them. But I don't think that's going to make a difference. We don't think there's any difference. I'm sorry?
I don't think there's any, you know, any good that can come of stopping that sort of treatment. Some with LHRH or whatever the opposite is.
Well, here's the thing. We've seen guys like Ken and Peter do okay on monotherapy. Monotherapy abiraterone and monotherapy.
Well, I did abiraterone for about 15 months and then it failed.
Okay. Well, so, you know, monotherapy, second-line anti-androgen, you may be able to get away with, but you need to be taking something. So if you're only taking one thing, then
I guess, you know, if it's not broken, I shouldn't really fix it, but it's my nature to wonder if tinkering with it could make it better, or, you know, sort of, there's a theory I have about cancer sort of figuring things out, and maybe I should keep it guessing.
Well, but Steve, I think the other thing about it is you're taking chemo right now,
Yeah.
right? You can't switch two things at the same time because you never
Okay.
know what
All right.
what made the difference, right?
Okay.
Want to change one variable and then we'll think about the other if you need to.
That makes a lot of sense. So it's just like sometimes I have to overcome my own nature. So this
No,
is
I
what.
mean, we're all that way, but the point, we're all what if and what else. But for
Right.
you, I would say let's deal with
Yeah,
one variable.
I mean, like I said, I mean, I also don't want to get cocky after 2 infusions, whatever is the right thing to call it, because who the heck, I know it's cumulative, and I know that I can't count on feeling
Well,
this.
Steve, you haven't told us if you've done a PSA since you started cabazitaxel.
Yeah, I came down from 133 to 124.
Okay.
And actually, they're giving me a PSA test every 3 weeks when I go in. So I'll have another one Thursday, and I'll know the results Friday.
Okay. Well, keep us posted on that.
Well, I had a physical, my annual physical in the middle of all this. So I had a full set of labs and heart stuff and so forth. And everything, there's not even really evidence that my immune system seems to be breaking down. My white blood cell count's been good. I take not in the last of the something with a P that's the same thing, 24 hours after chemo.
Procrit.
Right.
Yeah, there you go. And I mean, that injection, along with every 24 hours after the chemo, like, I feel fine from that so far.
Okay. Well,
good.
Guys, it's 20 after. I promised I would stay on for, I think the other 3 new guys may all have left by now.
I
But
hadn't
if
left.
anybody,
No, I haven't left.
Henry left for a minute, but
oh,
came
no,
back.
no. I mean the ones who didn't speak.
Thanks.
Sorry,
Okay.
Henry.
That's fine.
I meant the 3 who didn't speak. You and Vic are still here, but I think the other 3 guys who didn't get a chance to speak. We've got somebody called Eric on. Eric, is this the first time you're on the call?
Oh no, this is not my first time. I haven't been here. I haven't.
Oh, I know who this is.
Yeah,
How
yeah.
are you?
I'm all
Tell
right.
us
How
how
you
you
guys
doing, man.
doing? I'm doing pretty good. I go back at the end of this month, November 30th, for my 6-month appointment after my radiation. So looking forward to seeing what that entails. I kind of when I was listening, and I think it was Rick Jackson. I think it seemed like his story was could be a lot similar to what I could possibly looking into, because after my radiation I did a PSA and it was 2.7. It was down from like 10. It was 2.7, and so I'm going this week to take another PSA before my next 6 months appointment. So we'll see what my PSA is saying there and what I can look forward to. I have been exercising a lot more. I've been a little busy because my daughter's in her senior year in soccer. We've been traveling, so I haven't been able to get on as much as I would like to. So yeah, so everything's going so pretty good. Out of the conversation, I'm curious: is there any more like I know we talk a lot about medicine or anything, but is there any something like natural, like herbalists or natural things that I can incorporate in my lifestyle to kind of help supplement some of the medicine that I may be taking or going to be taking?
Anybody want to address that?
I don't have any empirical evidence to support it, but I've started drinking a bunch of green tea, eating cooked tomatoes, and working edamame into my diet. Those are all from that D'Amico video that I told y'all about, what seems like probably 8 months ago now on this phone call.
Yeah. All good suggestions, all really good suggestions, Henry. Eric, we've got some good diet webinars and information on our website. We've got a really good webinar from Greta McCare, who's the registered dietitian at UCSF. If you put Greta, Greta, Greta in the chat, in the search on our website, it should come up. There's also a reference there, a really good nutrition pamphlet. You know, there's a lot of good holistic suggestions that can be made. I mean, certainly the lycopene is very good. The only thing with lycopene is you really need it with a little oil, so you're not going to get it as much from other red fruits like, say, watermelon. Well, you may do if you do what I do, which is I kind of make a salad up with watermelon and I put a little olive oil on the salad. So you might get the lycopene released that way. I like the suggestion of the green tea. We've seen that to have a definite benefit. And the idea of taking in some soy with the edamame is also a really good idea. So I don't know if anyone else have any suggestions for
I try to eat
Those are
cruciferous
all,
veg.
I mean,
Oops.
all of those things are great antioxidants, right?
Yeah.
I mean, that's the common theme of what you're saying.
And I like what Steve Suff was going to say. Say it, Steve.
Yeah, I try to eat a lot of cruciferous vegetables. Plus, like I buy some supplements that are supposed to be cruciferous, enhance the whatever the sulforaphane. So I can't remember how to pronounce it, but so I take some of those every day.
So,
Which,
Eric,
you know,
cruciferous vegetables are things like cauliflower, cabbage,
broccoli,
Brussels sprouts, broccoli.
You know, I also do a little
Brussels
juicing.
sprouts.
Right.
Okay.
There was a really good guy making a presentation for Prostate Cancer Foundation about a month ago, who focused on cruciferous vegetables and broccoli. He was a guy who lives, I can't remember, he was a Brit. I think he lives in Canada, and he was all over broccoli. He thinks it's a super veg.
And I've seen a person who was a scientist come to meetings, and he was really into blueberries.
Okay.
The broccoli guy has, they actually have a production company that's in Australia that produces 3 different types of broccoli, and they make a soup out of it and sell the soup. One is extremely high, whatever the chemical is, and it has direct effects on prostate cancer growth. They really have a lot of statistical stuff on it. They have 3 different levels of the soups, but they don't have enough land to produce enough to get out of their country at this point.
Okay.
Yeah. So yeah, they're making a super sulforaphane broccoli, super broccoli. It's still green. I got to tell you,
that's the word I was looking for. Also, you can get a juicer and make yourself fresh juice of that every day. It's hard work. I do that with wheatgrass and some celery.
Okay. Well, yeah, I make my own little smoothie that's kale, cucumber, water, and put a little lemon in it.
I think that, you know, I don't know if it'll cure cancer, but it'll keep the rest of you healthy. It's kind of the way I look at it.
Eric, add some broccoli into that. Add a little broccoli into that, please.
Okay.
Okay.
So my wife did some research on that, and there's a Dr. Greger who is real big on nutritional fighting cancer, and broccoli is a big thing. One of the things that he found to release that chemical, if you're not getting fresh broccoli, is if you're getting frozen broccoli, after you cook it, sprinkle mustard, dried mustard on it, and it releases the chemical that is supposedly so effective in fighting off cancer. Otherwise, you don't want to. You want to get the fresh broccoli, is what I understand. But the guy's name is Dr. Greger. Apparently,
Yeah, he wrote a book called How Not to Die.
Okay, great. You're
which
familiar.
Is very interesting, and he has on YouTube. He puts out something every week or 2 weeks. Like I said, I don't think I think he's a little over the top, but one, it can't hurt you, and I'm pretty sure, and it makes your heart healthier and the rest of your body healthier.
The broccoli chart, they have some charts that were done with the different levels of broccoli, the 3 different levels. And the chart showed how much people's DNA changed, all their DNA from the before and after. And the highest end broccoli, the strongest, there was almost no discernible DNA change from the beginning to the after having it, which means that there's less changes to your body, less deterioration of your DNA once a week taking it. But it was really interesting, the chart showing the DNA effects.
I try to. I used to read them more. I've been a little busy lately, but I do love listening and watching that stuff. And how can you resist a book that says how not to die?
Guys, Eric, I'm so happy. Are you doing okay on the Relugolix? You haven't had any problems with that?
No, so I haven't had any problem. I've been finished taking the Relugolix since about August, in mid-August. That was like my last time having to take it. So currently I'm not on anything at the moment. And we'll see what November brings, because this time I did have the pelvic region radiated, and I had because they couldn't tell me if the lymph nodes was cancerous, but it said they looked suspicious. It was 2 lymph nodes, and they did put some radiation on that.
We are keeping our fingers crossed for you, man, and come back and talk to us. See, look at all this great information we're giving you, eh?
Absolutely.
Where else can you get that, eh?
Hey, nowhere. I learned more. I learned so much more here, and what to ask and what to look for than you wouldn't even imagine.
All right, so I'm hungry, so I got to go get something to eat. I got some broccoli in the fridge, I think. No, I've got green cauliflower. I've got green cauliflower in the fridge, which is close enough. Government work. Okay. Sorry, huh? Sorry. All right, everybody. Thanks for sticking around this long. And I'm leaving. Who's up next week? Peter Kafka. I'm leaving him a bunch of new guys. So, all right.
Thank you. Thank you very much.
Bye bye. Good luck, everybody. Bye bye.
Good night. Good night.